The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the August 2019 Pre-Hospital Care Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide at all levels to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal, we take a closer look at some of the latest research happening in EMS. I'm David Page, and I'm the director of the PCRF, and I'm joined by a talented group of individuals today. Dr. Remily Crow is a research scientist with ESO Solutions. She will be helping us with this podcast moving forward. Dr. Tony Fernandez, assistant professor at the University of North Carolina, Chapel Hill, and author of the EMS World Journal Watch. Dr. David Slusky, we're honored to have Dr. Slusky today. He is the author of the paper we will be discussing. He is with the Department of Economics at the University of Kansas, Lawrence, and is a healthcare economist, traditionally trained in Princeton. So with roots to Pennsylvania, and that will bring us to Dr. Doug Kupas, who is the medical director for the state of Pennsylvania and also an emergency physician with Geisinger. I have also, hopefully, Bill Toon tuning in at some point, and Dr. Corey is available if needed, but not necessarily playing a central role today. So we are here to discuss, did UberX reduce ambulance volume? Published in Health Economics this year. This review is paired with an article written by Dr. Tony Fernandez in EMS World, and we encourage listeners to check out this article on emsworld.com under the category of education and training. Thank you all for joining us. So let's begin. We want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. Dr. Crow, Remily, will you walk us through the original intent generally for this study?
Absolutely. Well, thank you all for joining, and I think today's article is really interesting as it comes from outside the bounds of our traditional medical journal articles. And this is an economics article, and it sought to answer the research question of whether or not the introduction of Uber services or rideshare services results in reduced use of ambulances. And so I think it would be interesting to hear just a little bit about the why behind the article. So Dr. Slusky, could you tell us how you got into this topic and why did you decide to take it on?
Sure. First of all, it's very, very nice, excited to be here. I think in the economics world, when we write about a variety of industries and areas, the hope is to get to talk to those individuals with our research and share our insights and also learn more and find new ideas for future papers. So thank you so much for having me. This paper life cycle kind of is one of the ideal ones for me, which is you hear an anecdote or a couple of anecdotes and you wonder, is that actually representative? Can we document broadly whether these anecdotes are part of a larger trend? And then in this case, once we've done that, subsequently, we heard from hundreds of individuals and anecdotes of people saying that this was their story. So I think this comes out of stories we were reading about individuals using Uber to get to the hospital in a variety of capacities. And so that was where we came up with this idea to work on this paper.
Great, and I think you hit on one of the central hypotheses, and that was that people who don't have other means of transportation might use Uber instead of an ambulance transport to get to the hospital if that service were introduced. Is that correct?
That's right, but I think it's even individuals who regularly have a means of transportation, but for example, and I'm not this kind of doctor, so I'm going to do my best here. Imagine your driving leg is swelling up to the point that you can't operate your car. Even though you have a car and normally have a means of transportation, you can't get yourself to the emergency room and need some other means of getting there.
That's super
Excellent.
fun. You have to think about disruptive technologies, right? So this is a game changer. It's a disruptor, and changed the way everyone thought of taxis. And I would dare say ambulance services may be just as complacent right now as taxi companies were in the past. We pretend that people should just call 911 and we'll get there when we get there. Or, if we make an appointment, we're late, well, tough, there was traffic. And Uber changed the way people thought of, gosh, I can see who's coming, I can see their license plate, I can even message them and be in direct communication with them, and they're accountable. And so suddenly this disruptive technology isn't just, I don't think, a game changer for the taxi industry. It could really affect ambulances. So I'm really glad you looked into this. Sorry to
Absolutely.
interrupt. Yeah, yeah.
I think another example, think about, Starbucks coffee actually made people spend more money on the other coffee shops near Starbucks because it changed how socially acceptable it was to buy coffee out instead of having it at home. The real sense that, like, I remember when I was a management consultant in New York City, and one of the partners would commute from the Upper East Side to Midtown by taking a cab every day. We thought that was just kind of the most frivolous thing in the whole world. And then now I meet numerous households, mine included, that have fewer cars than drivers because a handful of Ubers on the margin is much less expensive than owning another vehicle. So this taste changers and kind of social acceptedness of using something has made a big difference, absolutely.
Absolutely. And I know that we're going to be diving into the methods in a little bit, but I think it makes sense to talk a little bit about the study population here. And I know that a natural question that pops up for people that is addressed in the paper, but I think we should talk about it, is your choice to look at the introduction of Uber and not consider other services like Lyft. So could you tell us a little bit about the time frame and that choice?
Sure. There's a footnote in the paper that talks about this. And I think one of them is that we, actually my co-author, who was a medical student at the time, really almost hand-coded all the different Uber regions to figure out the zip codes in them. And that was a really labor-intensive process. And with all kinds of data collection, you have to ask yourself, what's the marginal benefit of future data collection versus the cost of and time? And since many of the other papers in literature had only focused on Uber, and in almost every case, Lyft entered a market after Uber was already there, we chose to focus on Uber for this paper.
I love it. When I read that part about zip codes, I started thinking, because if the premise is this reduces ambulance loads, it's people who probably have the means to pay for an Uber, which, because Uber is clearly less expensive than taxis and has kind of changed the way people think of that, I thought, I wonder if they also had some zip code correlation to low income, or these are mostly inside cities, so we're talking about kind of an urban experience, and the mean income in those zip codes might actually have a story to tell about it, as much as whether you chose states where ambulance services may or may not be either government run or privately run, and how the perception of EMS is in those places. It's kind of an interesting piece.
That's right. We thought about a variety of these kinds of time varying controls. So we included unemployment rates, number of broadband providers as a surrogate for smartphone usage, right? Because if you don't have enough smartphones and enough broadband, this isn't going to work. And a variety of other, age and chronic medical conditions. We didn't include poverty rates directly, in part because those are not changing so much in this time frame, given the short number of years that we're using. And this previews the methods a little bit. This is a relative estimate in the sense of it's a relative change in ambulance usage. And so there, we're not particularly worried about what we call time invariant, kind of things that are consistent over this time period, even if they're different across cities. If we're looking at the relative change, that should come out on the wash of the analysis.
Dave, this is Doug. You know, one of the things that strikes me sort of early on in this discussion is, I mean, I see almost two parts. You know, there's the deep dive into methods and that sort of thing, and whether there are things that impact some of the conclusions. But then there's just sort of this overall concept, which, you know, I think the paper is very interesting, taking a stab at just this, putting some measurement to the anecdote as was introduced. But your discussion about the taxis and how EMS may be coming or may be complacent right now, thinking they're the only game in town and this is all that they, you know, this is all in their bandwidth, and like taxis may find that there is an impact of other services. And you know, I think that's extremely true. I think EMS has had, you know, decades of function in the U.S. Largely in the same exact way, and there are some places that are working outside of those parameters now, but many still think that way, and I think it really is a trap for EMS to just think that people are going to call them for emergencies, and or that they even call for emergencies now. You know, we have some good data that people, you know, many people go to the hospital by private vehicle with chest pain, for example, because they don't want the attention or the you know, the lights and sirens and that sort of thing. And so, you know, some of our business is driven away by us already, and we don't even pay attention to that. But the point I wanted to make and throw in there too, that absolutely is of interest to me with this is, number one, I'm not sure that patients still make the best decisions. So, you know, when the chest pain patient decides to take Uber to an urgent care instead of an emergency department, that's probably not a good decision. How we help as a system to navigate so that patients are getting to the right place is important. And I also wonder about the Uber in taking, you know, I've heard anecdotal stories about patients going by Uber with significant injuries that are associated with bleeding. And I just wonder how, you know, Uber drivers that pick people up that are sick to the stomach and are vomiting in their vehicle or having, you know, diarrhea or bleeding, all these things that we take care of and clean in the back of the ambulance, but now they might be in your Uber car.
Yeah, I mean, I think that one part of discussion we haven't mentioned that's very related to this is co-payment and deductibles, right? And we have kind of an older generation that kind of designed their habits in a world when those things were much, much lower, right? So of course you call 911, and of course you take an ambulance to the emergency room with chest pains because the out-of-pocket cost was very minimal. And I think those individuals now are realizing that that's actually not true for them anymore, and are then updating and adjusting their habits. And I agree, and the research is very clear, patients don't make the best decisions and are not informed to do so. There's a paper in the Quarterly Journal of Economics looking at an employer that switched employees from a low deductible to a high deductible plan and found, as health economists have known since the RAND experiment a generation or two ago, that individuals will consume less healthcare when you raise a deductible. But what this paper showed very clearly is uneducated consumers are terrible at figuring out which medications and healthcare to reduce and which ones not to. They kind of just reduce everything, right? And this is, in some sense, in many ways, the most extreme example of taking an Uber when you have chest pains.
And I think we have good data in some places that show that, for example, ambulance transports from urgent cares to emergency departments seem to be at a much higher rate than they are from primary care physician offices to the emergency department. So if somebody goes to their primary care office, often they call first and they're told to come in, but if they just self-select to an urgent care with chest pain, much higher chance that there's a secondary ambulance transport and that they're not getting the care that they needed on the first swing.
Interesting. Well, and I think it's fascinating just to hear you talk about the population of early adopters in this time period of the study being probably younger smartphone users who were hip to Uber early, because, you know, over time, I think that population grew, as did the number of Ubers, right? Because, you know, early in Uber history, it was hard. You have to wait a little longer, and it wasn't as reliable, if I were to use that word, that that you'd get somebody to come pick you up pretty quick. But it's kind of a sweet spot between people who are not of means to call a cab or have the health insurance that they want to, that would say just we're going to call the ambulance. So it's a sort of a layer of the population and the gray area between I'm having chest pain or abdominal pain to the point of thinking I'm going to die and I should call an ambulance right away. And where these two mix together is that intersection of are we really using the EMS system the way it was intended when we all promoted 911 and said call all the time, just we'll sort it out. But in many major cities, and I'm real curious to get to your results, because once we get into the transport times and response times, you would assume that if there's more ambulances available, the response times would go down. But maybe, those are assumptions that are not actually born to be true. Anyway, we tucked into Remley here, and Remley, anything else just to kick it off, and then we'll get Tony to talk a little bit about the results here and the statistics.
Yeah, but before we dive into the statistics, there is one part of the methods that I would like to highlight, because I think this paper is so robust and so interesting. And as your resident data nerd, I'd like to talk a little bit about the data sources that you used. So I think something unique in this paper is that it didn't use just one source of data. So Dr. Slusky, maybe you can tell us a little bit about how you pieced together all of the puzzle pieces to tell this story. I know that you use some of Uber's data and Nemesis data. Could you just tell us a little bit about where you got all the data from?
Sure. On the data side, so the Uber data came from their website. So this paper was done with public data. We had no proprietary data from Uber on this. And so Uber would announce on their blog when a city was getting UberX in this case. And I should mention back on the availability, we're not looking at Uber Black, we're looking at UberX, which tended to be more available and available in more areas. So the regions were on the website, and we could figure out which zip codes were in each of those regions. Then the Nemesis data, so then this was for all the economists listening to this, that and other social scientists, that having a physician collaborator who knew about other data sets was really amazing to me, because I had not worked with the Nemesis data before. But Leon was aware of it and was able to broker a relationship where we could do this. And as happens in a lot of these papers, Nemesis has very clear rules and protocols about what kind of data they're allowed to give out. And so their first reaction was, we can't give you anything that identifies any cities or regions. And our response was, we don't need that. All we need you to do is merge the Uber data for us by location and time, and then send it back to us with a dummy variable saying, these 4 observations are city 1 and these 5 observations are city 2, but I don't have to know who city 1 and who city 2 are. And so negotiating a situation where we could be compliant with their totally justifiable and understandable rules while doing the analysis we needed was a big part of this paper. And then, in a kind of distant third was a variety of other public data sets that we use to control for other time varying factors. I mentioned some of them already: smartphone usage, proxied by broadband providers, chronic conditions, age and such, from a variety of public data sources.
So I'm just dying to ask you, because in LA, I use Uber all over the world actually, and when I get to LA, I can actually order up a van that's a wheelchair van, or an Uber that speaks Spanish, and I don't see that in other markets. There's not that many options. So I wonder if you took some of that into account in markets where Uber has very specialized services, and I'm just waiting for the next time I swipe over, there'll be an Uber paramedic, and it'll be a not only do I get a ride, but I also get a little consult with someone who can help me out. I'm curious. Did any of that play into this?
So not in this paper. I have not seen publicly available data on what types of Uber are available in each region. I mean, I think you'd almost have to sit there with your smartphone and move the map around to each city to get that point in time. On the Uber paramedic thing, I mean, I have mentioned this in other conversations about this paper, and I'm happy to have this conversation more broadly. There's a lot of space between an UberX and an ambulance, and a lot of space for EMS providers, for 911 operators, for cities to get into that space. In my conversation with Uber and in their reaction to this paper, I think they are publicly very not interested in that space for primarily, I think, for all kinds of liability reasons. I mean, even the new Uber Health platform they're working on is explicitly non-emergency and even non-healthcare, and just designed to better coordinate with the healthcare transportation needs of patients getting to and from their appointments.
Yeah.
So I would love your all thoughts on, you can imagine a whole variety of, kind of a cop car with lights and sirens, but is not a mobile emergency room, driven by a paramedic with a defibrillator and an oxygen tank and a med kit, to something a little bit, just a regular car driven by somebody with basic first aid training with a first aid kit, right? There's a whole continuum here. And so I would love your all thoughts on kind of how possible that is, how we figure out how to get the right thing to the right person.
Well, let the speculations begin, and I'm sure Bill Toon will have some colorful ones. But
wait, that was my clue.
No, it wasn't. Shut up. Listen. Anthony, who's one of our listeners, actually has a really important question, which is, does Uber have any policies on 911? If they notice a person is actually, appearing ill? And that's a really good question that probably an Uber driver would know, and I don't know that we have any on the call, but if there's anybody listening that does know the question, or the answer to that question, I've never seen them actually react that way. I think they're more disgusted, like Doug said, when somebody, has some emesis in the back of their vehicle and leaves a mess. But they just seem to be content with, like any other normal human good Samaritan, I'm going to help you out. And I don't know that there's. Did you find anything, Dr. Slusky, in this area?
We did not specifically. Some of the local news stations that have covered this paper have spoken to Uber drivers who have, as you can imagine, a variety of opinions about this. Josh Angrist, who's a noted economist at MIT, did, I think, become an Uber driver briefly for some of his research on Uber. As an untenured faculty member, when I wrote this paper, I did not think that was a justifiable use of my time. But now as a tenured faculty member, as I think about a future Uber paper, maybe I'll sign up to become a driver just to get a sense of
observation. The anthropological part of this thing. I love it. I love it.
Great. Dave, this is Doug. So, the one thing I would say in response to some of what Dr. Slusky said was, I think that to some degree, when I think what we're doing right now with ET3 and having CMMI, somewhat encouraging with a few sites, nurse triage for the lower level 911 calls that could then either direct them or maybe, potentially direct some of them to Uber to an urgent care versus some other route to, this space in between. I think there's great possibility for EMS as an industry to help manage, help patients navigate that space, still be viewed as the place where the call comes in, and then navigate the right care and the right patient to the right settings.
Dispatch an Uber when it's appropriate.
And whether it's Uber or whether it is something less than a full ambulance, is certainly opportunity for the industry. If it doesn't happen, somebody else will fill the void. Or in many states, our laws are so archaic that it doesn't allow us to do things that make more sense or are more efficient and are still the right care the patient needs. And clearly that we have to recognize that too.
Yeah, there's a whole dispatch angle to this, just about, I was talking to my wife about this, and she just prepping for this podcast, and I was trying to explain that just by hitting the button, I don't have to explain to a dispatcher, I need help, this is where I am, this is an emergency, this is, this is the location. And it would save minutes sometimes if we can just say, button here, now, I need you, immediately. and this interaction with the triage and getting the right resource can sometimes just end up being a barrier for the real case where you really, every second counts. But I'm curious, Doug, you just slurred some ET3CMMI abbreviations that maybe not all of our listeners even know about. So just quick, what is ET3 and what's CMMI?
Sure. Sorry. To not make it this about that, ET3 is the emergency triage, treatment, and transport model that Medicare, the Centers for Medicare Services, has proposed through their innovations group, which is the CMMI, who looks at innovative ways to deliver healthcare that is better, cheaper, and has high patient satisfaction. So that project is in application phase right now, and really some of what's in that are a small reach to that space in between a 911 full ambulance to the hospital and the Uber that we're talking about. But there's a lot more space there than what even the CMMI project tries to put a dent in.
And where can somebody go get information about that if they were interested about it? Just at ems.gov?
Probably cms.gov and look for ET3.
Great. Okay. And Dr. Slusky, you have a question.
Yes. So on that dispatch and triage piece of it, are there ET3 proposals around video 911 calls, around the the smartwatch biometric readings, on the integrating with somebody who has a glucose monitor?
You're a dreamer. We can't even get the location of the stupid cell phone half the time. Wouldn't we love to be able to have video communication back and forth with the patient and their EKG from their little Apple Watch? That would be just too forward thinking. Sorry, that's
no. The joke is PhD is Latin for a doctor who can't help you.
Okay.
and so I can't splint femurs, so I have to think about how to do other things.
So this is Bill Toon, Dave. So since we've derailed ourselves a little bit here, I think that there's been historically over time, and from my experience of traveling around the country like yours, it is interesting that some systems have created hybrids that are older than this, such as the 911 ambulance gets there that's run by the city or the fire department, and they determine that it doesn't deserve their stuff. So I've seen situations where they ask the patient, do you have money? And they said yes, and then they call them a private ambulance to take them to the hospital. And not disclosing experience that I have in an urban city in an undisclosed location in the Northeast, it wasn't unfamiliar for us to do the same thing, get to the scene, assess the patient, determine that they just need a cab ride home, and we'd hail a cab for them and put them in the cab, and off they'd go to home.
Fascinating. And then we'll get into the papers on non-transport and death from abandonment.
No, we won't talk also about
triage.
How we were going to do that. But what about Uber? Imagine if Uber, as technology and everything here increases, imagine Uber with an AED and a pulse point application.
Well, that's what Singapore did. Is it put AEDs on all the cabs? Let's get back on the rails here. And Dr. Fernandez, Tony, walk us through the results here.
Fantastic. I just want to again thank you all for joining us today. I think it's been a great discussion based largely on your results. So we really appreciate you being here today. So let's talk a little bit about your results. And before we get there, I do want to just touch on your NEMSIS analysis really quickly. You relied on NEMSIS to calculate a lot of things, specifically because they can't give identified information out. And we talk a lot about NEMSIS on this podcast, and that they have a research data set that is typically free of charge. With your interactions with NEMSIS, was this the analyses that you asked them to perform for you? Was there a charge associated with that, or a long wait time, or was that were they pretty easy to work with on that account?
So the NEMSIS team was spectacular to work with. I wish other data providers were as kind and helpful as they were. There was no monetary charge for us to work with their data, but there was a queue in the sense that, when there were a couple of months when they were, working on another year of data to be released more broadly, we, had to get behind that for our requests. And so I should also say, therefore, that I'm very grateful to our editor at Health Economics, who was willing to extend our revise and resubmit deadlines so that we could wait until we had the additional data we needed from NEMSIS.
Fantastic, and thanks for going through that, because we have a lot of budding researchers on the call, so I think that understanding what they have access to is certainly helpful. So I appreciate that. Thank you.
Sure.
Let's run through some of your methods. So you looked at Uber and ambulance response rates, and what you got from NEMSIS. It seems like the overall ambulance rate was about 18% through all of the jurisdictions and time periods that you analyzed. Would you say, was that higher than you expected, or was it about what you expected going into it, or did you have any basis to assess that?
I think it was 18 per 1,000 residents per quarter.
Okay.
This is where I think having a physician co-author was really helpful to me, because he had more basis to look at that, and it didn't seem out of place to him, and it's good to have co-authors you trust. So it seemed reasonable to us.
Excellent. And then you ran a regression model, and you accounted for some pretty important things in your regression, where you had whether Uber was available for the complete quarter or not, time and city time effects, and city level control. So this is a pretty robust analysis that you ran. And as we talked about earlier, you got these from a lot of different data sources, which I think is really impressive. When you went through, you ran a host of models. I think we have 6 in table. Oh, table 1 is a summary statistics. Do we have table 2? Can we put that one up? Yeah, so you ran 6 models adjusting for different data points that you collected. And overall, I believe that you found that there was about a 6.7% reduction in ambulance calls. I believe that's per 1,000 also, based on the mean that we talked about earlier. And that was using your 5th model here that we based that estimate off of. Is that correct?
No, I think it's the 4th model, and I think we did that not because we have more or less confidence in the 4th model, because it was the smallest of the controlled coefficients, and so we wanted to use that as a lower bound. Excellent.
And then if
I think, sorry, just a quick note for listeners who are not as familiar with models is, it sounds to me, Dr. Slusky, you were trying to address this issue of, is there correlation versus causation, right? So the more numbers you tried, not just, you're trying to tease out whether there's just some sort of abnormal dip in the use of ambulances at the same time as Uber comes up, or if it's actually caused by this as much as you could determine. So you're trying to dig into, fixed effects geography, quarter, year, and you've got a whole bunch of information about the chief complaint of the patient, the 911 time to response, the transport time, and you address it in your paper as to the expected results of each one of those variables. So these models you're referring to are just different ways of modeling the statistics, correct?
That's right. I think there are 2 different questions we're trying to answer here. Kind of one question is this association we're finding robust, right? Is this not just statistical noise that I can show you if I cherry pick one model and don't show you any other ones? And in the peer, I don't have time to go through all the drafts with you in the peer review process, but I think one of the most important parts of the peer review process in economics is that the referees will say, and I say this when I'm a referee, well, how about these 5 other specifications you didn't try? Right, and you as a responder want to come back and say, well, I tried all 5 of them and the results are indistinguishable. So that's one side. The whole second piece, which I don't think is in this table specifically, is now I'm pretty sure there's a correlation, there's an association here. what can I do to convince you beyond a reasonable doubt that this represents a causal effect? And that's, I think, where some of the other tables, specifically tables 6 and 7, really try to get into that piece. Kind of what else might be going on here, and table 5 as well. What else might be going on here? What else might be driving the results? And can I rule out other channels that would call into question this kind of causal analysis that I'm trying to do?
Fantastic. Great. Well, I appreciate it, because that's excellent to let our readers know that there are the implications of the analysis that you did. So I'd like to move on to a discussion of your analysis of lights and sirens. I think this is table 4, yeah, right here on the bottom here. And for this, I believe you did use the 5th model from above, table 1, and you sectioned this out to lights and sirens and no lights and sirens as a measure of severity. Maybe you can talk to us a little bit about that and why you chose lights and sirens as a proxy for severity.
Sure. So the question here is, okay, you show this Uber, is reducing ambulance volume. Whose volume, right? We have a distribution of severity. One hypothesis would be that it would be from the least severe cases, right? The cases when, if you had called an ambulance, the ambulance isn't actually even going to use their lights and sirens. They're just going to drive with a normal flow of traffic. And so that was, we wanted initial impressions and from NEMSIS, so we could try to actually calculate severity. We weren't able to get that, and so this was, I think, the best variable we could get. And so what we did here is we kind of calculated, instead of all ambulance calls versus overpopulation, lights and sirens ones versus not lights and sirens ones. So if you add up the means in table 1 or add up the coefficients in table 4, they actually add up to the total number, which is mechanically what you'd expect. And our hypothesis going into this was that we'd find most of the effect in column 3 and not as much of the effect in column 2. And that's not what we found. We found, if anything, more effect on column 2 than column 3, though if you run the kind of test to see whether these coefficients are distinguishable from each other, you don't pass that test, meaning that even if one is statistically significant and one is not, and their magnitude is different, based on how noisy those coefficients are, you actually can't, to use statistical language in this, you can't reject the null hypothesis they are the same. Meaning, if you ask me, based on this information, can you conclude beyond a reasonable doubt that there's a difference between columns 2 and 3? I would say no. Right? I can conclude that column 1 is different than 0, but I can't conclude that column 2 and 3 are different from each other. And so, unfortunately, that left us kind of with not able to say anything, that we'd need much more granular data from NEMSIS or much more granular data from some other kind of electronic medical records to really delve into this question. And it wasn't one we were going to be able to answer with the data we had available in this paper.
Yeah, and I think that that's a great point, because there's a lot of discussion around lights and sirens in EMS, and whether or not lights and sirens is used actually based on clinical need or judgment, or if lights and sirens are used based on policy or culture of an agency. And that's a discussion that's ongoing right now. And so, frankly, I am not too surprised that you didn't see a difference between lights and sirens and no lights and sirens, but I'd love to hear what the other panelists thought about this result.
And you hear crickets.
Yeah.
Well, I do think it's the dichotomy between, you would think that the use of Uber would really be for people who did not, non-emergent responses. And so it's counterintuitive to think there'd be a decrease in emergency responses if the constant remains that people who are really having a medical emergency just dial 911. But it's this gray area where people think, is this really going to kill me? Do I really push the panic button right now?
Just a point of clarification, yeah. Dave, I think that the lights and sirens that Dr. Slusky was referring to in his paper was for the transport phase of the ambulance call. Is that correct?
That's my understanding. I don't think we have any information beyond the transport phase here.
Yeah.
I should also mention that our reference for using lights and sirens actually is Dr. Kupas's. So that was our the reference that we found suggesting this without better information was a plausible proxy for severity.
Yeah, meaning right when you transport. Yeah. Fascinating.
Very, very fascinating. So let's dive into more of the results here. I believe so. We found on under table 3, under table 4, you talk about that you interpret the coefficient to mean that when Uber is available in a city, there's at least 1.2 fewer ambulance trips per 1,000 residents per quarter than there were before. And then your main results, you talk about a dip of ambulance volume of 6.7%. Can you help us and the audience understand the difference in these two, or the similarities in these two results presented?
Yeah. So the 6.7% is if you take the negative 1.2 and divide it by the average of 18, that's where the 6.7% comes from.
Fantastic. So that was in, and just for the readers, that was in table. If you have the paper open, it was from table 2. That was the 4th model, and then the 1.2 percent, or the 1.2 decrease per 1,000. Where how do we interpret that result?
So I think that's the same result. I just didn't write 1.244.
Ah, gotcha. Okay, excellent. Excellent. So a 6.7% reduction. Well, that is certainly a meaningful dip, because we're talking about a national assessment here. So how do we put these results into context, and what do you think this means for EMS going forward?
And I think this is the disruption issue we've been talking about. And it's also, I want to go back to something we talked about before, of we're kind of talking out of both sides of our mouth on, we as a country, not we as a podcast, about patients. Right, on the one hand, we put patients in these high deductible plans with high coinsurance and high out-of-pocket maximums to say, we want you to be an informed, better consumer about your health care. And then the other side, we say, patients have no idea whether the symptoms they're experiencing are a true immediate emergency or something that needs to be monitored at home over the next 24 hours, right? So we're really trying to have it both ways here. And I think this is one of the many factors of that, is that patients who have health insurance, but it was going to set them back $2,000 or $1,000 to take an ambulance, are often making a decision that they're just not going to pay that much in anything but the most dire circumstances. And so I think there's both a EMS conversation about, when we spoke about this a bit earlier, kind of what are the spectrum of other things we could provide, and how could we have a triage system that can allocate those appropriately. But the other side, and this is a conversation I think we're having nationally now, is what's the appropriate kind of financing and allocation mechanism for healthcare to patients? We have one, which is kind of the you have insurance or you don't, and if you do have insurance, you have a high deductible. It's not clear that's a particularly good mechanism, because it results in things like this, which sometimes might be fine, but sometimes might not be.
You know, when smart people talk, usually I stop and listen, and I really want to thank you for coming on and discussing this with us, and just the concept that I think from the street side we think of fixed costs a lot of times, and you're as an economist thinking about how money drives decisions, and we're thinking about how the severity of the injury might or what people would or wouldn't do if they knew, you know, they were really injured or sick, and it's fascinating to have both disciplines intermingle, and I just applaud you for working with obviously an emergency physician or a physician on the paper. You know, we have a bunch of folks online that have been chiming in, and I want to make sure we're addressing some of them, some of their questions. So number one, we did have Bill Robertson, Dr. Robertson, look up an Uber safety policy page, which does say that if you need emergency help, it's mostly during the time that you're in the vehicle, you can contact 911 in the emergency button in the app, in the safety toolkit, which then gives you a live location and the vehicle information, license plate number, which you can either quickly share with a 911 dispatcher or can be sent in some systems, a growing number, it says US cities, this information is automatically provided to dispatcher. So that's pretty cool in terms of, you know, what happens when the thing goes sour and you have a patient in the back that's, you know, kind of getting sicker and sicker, or you get into a crash, etc. The other question from Shelley was, did you, the authors, find anything in NEMSIS or the data sets you were looking in as to the patient entering information about how they were feeling? So does the Uber app, did the Uber app capture, or did any of the data sets capture a communication back to the system that says, I'm not feeling well?
That's a great question. We did not use any of Uber's proprietary data, which that kind of text response certainly would be. But even in the papers I've seen that have used Uber's data to look at drivers' supply, to look at how the prices and demand affect individuals, I have not seen anybody use those fields. You need a pretty sophisticated text processing algorithm to, you know, parse all of those comments into things that were medically related. I imagine Uber is using that text. I will say I am also a frequent Uber user, and I don't think I've ever used that field for anything, health or otherwise. Yeah. So I don't know how commonly used it is, and I've certainly traveled Ubers with my family, with luggage, with car seats, with all kinds of stuff like that, and I don't even normally use that field.
So fascinating. The other question here coming from our own UCLA EMT and paramedic prep classes that are listening, so they can jump up and down now that we've mentioned and plugged them. In Los Angeles County, really the licensed private ambulance providers are prohibited from dispatching and responding to transportation and transporting patients that are 911 calls. So there's this, in different cities where you were looking at this information, there's different policies about, if I want to call a private ambulance in Denver, I can just do that, and the ambulance will send an ambulance. The ambulance service might send one from across town, or you know, if you're lucky, maybe they were just hanging out nearby. But did you take into account some of those systems where, you know, maybe the 911 system, and assuming everybody reports into NEMSIS is another kind of dangerous assumption, because not all 911 systems are reporting into NEMSIS. Tony, do you know for sure how robust of a reporting system we have to the point of privates picking up and sending data into NEMSIS if they don't really have to, if they're not forced to by a state?
So public and privates, they all report to NEMSIS. It is based on the state. So there are some jurisdictions like California who the entire state doesn't necessarily report, but they have jurisdiction within California that do report. There are some states who report all of their data and some states who report none. NEMSIS has a great website and a map on their on that website that says what states do report and what states report partially. And it is the last paper that was done, unfortunately, that describes NEMSIS data was back in 2011, and that was a different version of NEMSIS data. I'm not going to geek out on different versions of data too much, but I will say that there's a substantial difference between the versions, and probably in a good way, but moving to the new version 3 data has changed the reporting a bit. And so there's good representation, typically from the South and the Midwest. The Northeast is slightly underrepresented, as in their last paper, and if you look at their website, as well as out West, California, the whole state doesn't report. So, but they do have public and private. It's just up to the agency or the state whether they send that to NEMSIS or not.
So there may be some holes there, some Swiss cheese that we don't really know where the.
There certainly is. There certainly is. I think that that shouldn't be a big knock on NEMSIS. I mean, in terms of public health or medical data sets, EMS is certainly the only one this large that has a standardized data set, particularly if we compare to in-hospital data. And they do have a large representation, but I think you're going to get bias with any data set, and NEMSIS is a pretty good one as it stands.
Just may be helpful here for me to walk through table 7, which is we and our referees were definitely worried about this question, and just to walk through what we did here. So, it was touchy with NEMSIS trying to figure out what they would tell us, and so we're able to calculate kind of this NEMSIS coverage ratio. NEMSIS didn't want to tell us kind of the total number of reporting agencies per city, because then we could figure out which city it was. And so we said is just normalize it. Just take whatever quarter for that city had the most and make that one, and give me all the other quarters for that city relative to that one. And so then the first thing we've done here is we've looked at the correlation in columns 1 and 2 between that coverage ratio and Uber availability. And so we didn't find anything there. And then column 3, now we've looked at our main outcome, columns 3 through 6, the per capita ambulance rate. That is very heavily correlated with the NEMSIS coverage ratio, which makes sense given this is per population. The more areas that NEMSIS is in, the more ambulances we're going to see just mechanically, but it doesn't have much impact on our main coefficient. And so then what we did in columns 4 to 6 was we said, let's stratify the cities into the ones where there was constant NEMSIS coverage and the ones where NEMSIS coverage was changing. And we actually found, which was only maybe 10% of them. And we actually find in column 4, the coefficient is much smaller for the ones where NEMSIS wasn't changing. And a lot of variation is coming from the places where NEMSIS was increasing their coverage. But that if you kind of do this horse race, you control for both in column 6, our main coefficient is very much still there. So, we found that NEMSIS coverage is correlated with ambulance per capita rates, and that our results are from the places where NEMSIS coverage is changing, but controlling for NEMSIS coverage doesn't actually affect our results. And NEMSIS coverage itself is very uncorrelated with where Uber was rolling out. Lest you think that Uber was kind of trying to figure out where NEMSIS was changing its coverage and rolling out relative to that, which is a very implausible story.
Yeah. Fascinating. The more I hear you talk, the more I'm just amazed at the number of ways in which you sliced and diced this to really make sure that you weren't going to say something that wasn't true. There's a question here from Roger to go more into the analysis of the study population, perhaps based on zip codes, and is this difference the same if you controlled for or did a sub-analysis for socioeconomic areas where there's maybe fewer bus routes, food deserts is what he says, and fewer cars. So is there, are there places where Uber is used more that really affect this greater than 6% in some zones?
That would have been great to study. We did not look at those specifically, and I think one of the main reasons was NEMSIS was justifiably concerned that the more things we asked them to merge in, the more we would have created our own key such that we could back out which city was which when they sent the data back to us, right? And so we had to kind of rank which things we wanted to test the most because we knew we weren't going to get our whole list without giving ourselves a key to undo NEMSIS's confidentiality process, which they
Yeah.
understandably wouldn't let us do. And so those were the kinds of things that we would love to have studied, but just didn't make it on the list. And you can imagine a different analysis by different researchers certainly could study those things. And I encourage anybody interested to work on that.
Yeah, it does seem, for those that want to do research, that there are ways in which the economic world, or the world you live in, look at these problems, and they're definitely different than what we look at. Another question here from Michael Caduce at UCLA was, did the authors at all share the results with Uber? So did you contact Uber and say, hey, you realize that you're impacting ambulance operations, maybe time to teach your drivers how to do CPR and how to stop the bleed? Did that play?
We did not do that when we released the working paper. Uber did issue a statement about our paper. Since then, though, I have, which kind of is, I think, the statement that if I were their lawyers, I would tell them to write, which is, kind of, don't do this. We have since had some very productive conversations with various individuals at Uber about future areas of collaboration, using their proprietary data and thinking about ways we could expand this study into a much more granular level to get to all the kinds of questions and things we've been talking about. But we're still in discussions about those.
Yeah, interesting, fascinating. And Roger had a follow-up about, are there not places where Uber drivers actually are leery of even taking calls or picking people up who might look sick or might look or might be in undesirable neighborhoods? And I don't know if you came across anything that said, well, if I'm an Uber driver, I'm just going to kind of hang out not close to anything that looks nasty. Like, I'm not going into the bar district because I don't want to have drunk people in my Uber. Then I won't ever be near that. If I'm near the airport only, then I will only get that. Did you come across any of that?
My sense from Uber demand is that there are not a lot of flights landing after midnight, but there are a lot of drunk people who need to get home safely. So that's one Uber strategy. I'm not sure it's the most profitable one.
I love it.
But I will say, that's probably true, and probably therefore underestimates the impact Uber could have if the drivers were properly on board and the vehicles were properly, set up in a way to be easily cleaned and sanitized. But we don't think that would be different across cities specifically. And so I think that, this is the estimate of the effect. The effect is what it is. Again, it is probably smaller than it could be were these factors not there. But I don't think they're going to kind of bias our results one way or the other.
Nice. Okay. Well, as we come to an end, and this is always so abrupt when we actually shut the podcast, we'll all get disconnected. And I just wonder if the panelists have any parting thoughts about how this affects their concept, and what are the next steps for research. But how does this play on the street? Is this I see some reaction, and it sounds like the world outside EMS reacted to this. What's our reaction?
Hey, Dave, this is Remley. I think my key takeaway here is that this is a really important baseline paper for a world where the technology and the healthcare system are rapidly changing. So I think this is a really unique and important contribution to literature. And I just, again, wanted to thank Dr. Slusky for sharing this with us and sharing his time and a little bit behind the scenes.
Love it. Love it. Tony, any parting thoughts?
Yeah, I want to echo what Remley said. I think that it's really nice to see EMS data assessed in different ways and by different disciplines. This is one of the first times I've seen EMS in economics journal, and I think that being able to look at things with a different vantage point is really going to benefit our field. So I want to thank the author for doing this, and I think it's a good study.
Cool. All right, Bill, any thoughts as we finish?
Again, like everyone else, good comments, and thank you to the authors for doing this. It's, again, fascinating to see another discipline looking at ours. I think that it's just the tip of the iceberg of the changes that are going to come. And then we have to decide, do we want to be on that train of change, or do we want to get hit by it, or do we want to jump off? And I think that finding ways to incorporate and look at this stuff, I think we're in for a world of change delivery. And I really do believe that it would be very interesting in this country to teach Uber drivers to stop the bleed, have an AED, and connect them with pulse point, and see if that makes an impact on cardiac arrest.
Amazing. Well, I too echo these thoughts, Dr. Slusky. Seriously, great work, and thank you for entering our world and using, all of us enter all these charts into our electronic databases, and they go up to NEMSIS, and we never really know if it actually matters to anybody. And here, you've given us a little gold nugget and rocked our world for the day. So I'm sure people will tune in and listen to the archived version of this podcast on emsworld.com/PCRF or on our own website, prehospitalcare.org. And for those listening, please join us for our educational research podcast later this month on Friday, August 23rd at 10 a.m. Pacific, noon Central. We'll be back here with our clinical podcast on the second Monday of the month, and that would be September 9th. And again, thank you to all the panelists. Thank you, Dr. Slusky, and we hope you can join us again when you dig deeper into this incredible subject, or some podcasting listener says, oh, I think we can help you with some additional information. So thanks.
Great. Thank you all so much.